Hello, everybody. My name is Kroom Lawrence, Chief Commercial Officer for Hemostemix. We're thrilled to have you. Today, we're going to be talking through VESEL Health Talks number 17, Peripheral Arterial Disease and Chronic Limb-Threatening Ischemia, a chance at wound healing and preventing lower limb amputation for those patients who are not candidates for revascularization procedures. So it's a pretty exciting topic, one that is vital to get right in the context of stem cell trends. We're going to talk about why autologous therapies are a viable and important option for investigation and consideration to save limbs and save lives. We're going to talk about the standard of care and the economic reality today of how chronic limb-threatening ischemia is being treated. What has changed in the last 20 years? What are the impacts, the costs to the system and to patients? We're going to talk about our autologous cell therapy, ACP01. It's investigational, not yet FDA approved. The administration pathway, how it works based on the clinical studies, our phase 1 and phase 2s, and in the case of compassionate use and in the states and countries around the world that allow this product to be used for CLTI and wound care and pain, how it can be administered safely and effectively. We're going to talk about a physician account onboarding and what best practices are for safe and effective administration. First, let me touch off on a little bit about Hemostemix, a Canadian publicly traded company focused on autologous stem cell therapies, founded in 2003, a winner of the World Economic Forum Technology Pioneer Award, which was when Hemostemix and its partners discovered that they could derive autologous cells from a patient's own blood, generate a sufficient volume, and reculture those cells to home into the site of need, regrow blood vessels, and to then began investigational studies to reverse ischemic disease. Hemostemix has completed 7 clinical studies to date with 318 subjects, almost 500 total patients treated across several indications in the heart and in the limbs and at wound care. We've published 11 studies. ACP is investigational, has ongoing safety and efficacy studies, and I hope you'll learn more about us at hemostemix.com. There are a number of interesting things happening in the world of Hemostemix. We are bringing a new teammate to the team, Sean Harding, who will be the director of our patient care and clinical operations. She's wonderful. Thomas is very close with her over the many years of knowing each other. Thomas Mink is our CEO, I should mention, a great man, committed to this cause. We have submitted our phase 1 IRB protocol for vascular dementia. We think that is an enormous and huge opportunity in a clinical landscape of almost nothing you can do in the case of vascular dementia. So that is big. We also obviously are working in the state of Florida under the SB1768 protocol to help in the areas of pain and in wound care. We'll talk a little bit more about that. But please visit Hemostemix News. You can see that at hemostemix.com. And we share everything we're doing as we go forward so that we can all learn how to benefit from a revolution in stem cell therapy. I do like to refer to the FDA Cell and Gene Therapy Roundtable from June the 5th. FDA Commissioner Marty Makary and CBER Director Vinay Prasad, both incredible guys. We're joined by 23 expert researchers in the area of stem cell therapy. It was an honest listening session to help accelerate safe and effective therapies to ensure that America is leading globally. We talked about, or this cell and gene therapy roundtable talked about building a U.S. stem cell industry as a top priority, trying to bring it back onshore, challenging deeply held assumptions for faster access, especially for rare diseases, and emphasizing gold standard science. In other words, what is the capability and business model and regulatory pathway for personalized medicine when someone's own stem cells are recultured to serve a particular purpose in the body, how can we bring that to market safely and effectively? I would encourage everyone to go watch this roundtable on YouTube. It is very informative. And we felt that this was wind in our sails, especially after 20 years of clinical development, that we're on the right side of these trends to personalize medicine. Some important treatment disclosures we cover every time we have our VSL talks. ACP01 is investigational and not FDA approved for commercial use, except in the case of Florida for pain and wound care under state regulations. There are global locations that allow commercial access for compassionate care. We'll talk more about that. There are a series of clinical trials that have been completed. There are more coming that also allow access through those clinical studies. And we'll talk a little bit about our IRB protocols in the next couple of minutes here. Patients are required to provide and their informed consent in the context of their physician consult. Every patient should consult with their primary care doctor and their specialists, whether they are vascular surgeons or podiatrists or neurologists. What we're talking about here does not constitute medical advice, and we are focused on providing education and training and resources to all of the Hemostemix community so that the ACP01 platform can be considered in the right legal context and in the right healthcare context for the right patients. So please always consult your healthcare provider before making any treatment decisions. And our mission remains clear that early intervention is creating abundant opportunity to help transform end-of-life care into possibilities for healing and recovery. We'll talk a lot about end-stage peripheral arterial disease, where unfortunately, and in many cases diabetics, must have a limb amputated. And so in that context, what we're saying is you don't have to suffer through these horrible consequences at end of life. We should be talking about how can we restore blood flow safely and effectively to prevent very costly end-of-life care, but also the horrible morbidity and mortality results that are occurring around the world. We have many, many scientific references. Here are some of them that I would encourage everyone to look at. These are more focused on our cost analysis, and we're going to talk a little bit about that now. But critical limb-threatening ischemia, when you really look at the care and the science, there hasn't been huge progress in the last 20 years. In other words, as you go from diabetes to end-stage peripheral arterial disease, into revascularization procedures, into amputations, too many patients end up with an amputation either below the knee or above the knee, 150,000 in the United States, several hundred thousand around the world. So the insight here and the challenge is that rising diabetes and obesity will worsen this epidemic without new solutions. We also know that amputation dramatically reduces quality of life, but also the duration of life. The mortality outcomes are horrific. There's a 5-year mortality rate of 50 to 70%. That's actually worse than many cancers. So what happens is there are discharge outcomes that after an amputation, 60 to 75% are discharged to skilled nurse. Only 60% are discharged to skilled nursing and rehabilitation versus 30% after the standard of care revascularization procedures. Mobility is challenged, that 40% are really ever fitted properly with prosthetics, and that 15% of above-the-knee patients ever walk again. The pain is horrific. There's chronic phantom and residual limb pain in nearly 100% of patients with amputation. And then even minor amputations is a bit of a misnomer. There really is no such thing as a minor amputation. All these challenges and risks or costs carry through whether they're major or considered minor amputations. Lifetime amputation costs often exceed $500,000 and as much as $1 million. So after an amputation, it's not just one prosthetic, but there could be more, and there are ongoing costs. The first 2 years of costs, around $91,000 for an amputation, ongoing prosthetics and maintenance, $250,000 in long-term survivors. that the CLTI reality is shorter life expectancy and concentrated costs in the first 5 to 10 years. So the best practice, from a cost perspective, is to really discuss with hospital administrators and your healthcare providers, who are advocating limb salvage programs. In other words, what are the things we can do to save limbs and save lives and get these costs down? We'll also look at some of the numbers as it relates to 5-year costs of amputation, coming at around $200,000 to $300,000 costs, all in to the providers, to insurers, and into patients. So a major amputation at 5 years, inflation adjusted, is somewhere around just below $240,000 for a major amputation. And then revascularization procedures are coming in around $50,000, $50,000 to $70,000. And so, 80% of this is funded by taxpayers through Medicare and Medicaid, and payers are actively seeking lower cost alternatives to very expensive end-of-life care. What's more, and I was watching this fantastic webinar last night from Save a Limb, Save a Life Foundation. I would encourage everyone to go to that website and watch their educational webinar from last night. They talk about the amputation lottery, right? Amputation risk depends on who and where you are. So there are significantly higher rates among people of color and Medicaid patients. Lower volume hospitals and certain regions in the United States are showing 2 to 3 times the rate of amputations. And really only one in 3 Medicare patients sees a vascular specialist before amputation. And so this discussion was really around, how can the vascular surgeon, do more, right? So it's not just go right to amputation, but empower your vascular surgeons to perform angiographies, and essentially to take a timeout before the amputation. And this was coined by our friends at the Save a Limb, Save a Life Foundation. TOBA, timeout before amputation. Consider arterial evaluation. Perform the angiographies. Allow the vascular specialist to consider vascularization procedures. It is essential. It works in terms of saving limbs or deferring amputations. But the current standard of care still leaves 45% of patients as no option. So even if you go to a vascular surgeon and the diagnostics are performed correctly, the ankle brachial index of less than 0.4, ankle pressure, looking for pulse in the foot, even with revascularizations, there are still many reasons why patients cannot be a candidate for revascularization procedures. And we're going to talk a little bit more about that. So these are patients that are undergoing wound care, maybe hyperbaric oxygen, analgesics, but they're progressing to amputation. It is just a pathway that needs more attention. So what reduces amputations today? Certainly multidisciplinary teams. Wound care, vascular surgeons, podiatry. These groups are the heroes of the healthcare system. They're working every day to help patients prevent or reverse damage to their extremities caused by peripheral arterial disease, which is exacerbated by diabetes and obesity. But the simple bedside pulse exam is very helpful. And then certainly this timeout before amputation. So don't go right to amputation. Take a moment. Look at what the options are. Talk with your vascular surgeon. And then certainly from our perspective, take a look at regenerative therapy. There are robust clinical pipelines. See what are in the pipelines. Look at the clinical trials that are available. And so for those patients that are essentially called no option patients with CLTI, where traditional care cannot help, ACP01, our investigational stem cell therapy, may provide a new bridge. How? By promoting natural angiogenesis in the ischemic tissue, by healing ulcers, by reducing pain, and preserving limbs. And so we're going to talk about our clinical studies that are phase 1 and phase 2s. We've got some data coming up here. But consider that there may be another option, something to talk about in the context of what really is a $200,000 to $250,000 cost of care. So the stem cell revolution is here. Earlier we talked about Hemostemix, over 20 years of clinical investigation with angiogenic and autologous stem cells. Let me break that down. Angiogenic refers to regrowing of blood vessels. Autologous refers to using a patient's own blood. 318 patients have been enrolled in our studies, 498 patients totally treated. That includes both cardiology. We've done work in cardiomyopathy and angina, and then also, chronic limb-threatening ischemia and limb salvage and wound care, 11 peer-reviewed publications. These studies are our true north. They are essential. They provide the scientific evidence that these stem cells have data, covering both safety and efficacy. And so let's talk a little bit more about that. It's also important in the context of a very robust regenerative medicine industry around the world to look at what is autologous versus allogeneic. Autologous are stem cells from a patient's own blood. Allogeneic are those from donors. What we like about autologous cells, because they're your own blood, your own peripheral blood taken from a simple blood draw, that there really is no rejection or immunological risk. There is no contamination from somebody else's blood. There are no ethical concerns. There's no fetal or embryonic tissue. So there's zero reported malignancy risk as well. Excuse me. And that the regulatory pathway is being made available in certain states and in countries around the world for compassionate use. But we'll talk a little bit about Florida having provided access under Senate Bill 1768 for pain and wound care that we think is amazing and fantastic. Why? Because it's providing leadership at the state level to say if a physician and a patient agree and the patient provides their informed consent, the doctor's staying in their area of expertise, that they may come to a decision together to potentially try a stem cell therapy. And in our case, what we suggest is autologous stem cell therapy from a patient's own blood. So there are trends driving further adoption of stem cells. Patient demand. So patients want to find options that help preserve their limbs, their mobility, their independence, and avoid amputation. That is just a simple fact. Amputation is horrific, necessary in some cases, but if it can be avoided, that is absolutely better. There's an ethical dilemma. Too many patients, as we talked about, especially our minority patients, here in America and around the world, they often, skip through potential revascularization procedures, or certainly the consideration for stem cell therapy, and they're advanced right to the pathway to amputation. The payer priority, the system is absorbing $250,000 to $500,000, over 5 years, going up potentially to $1 million over the lifetime of cost. So the payers absorb enormous cost. Wouldn't it be better to have a regeneration of blood flow and avoid expensive end-of-life care? And then certainly Florida's leadership is a shining light, for everyone to enable autologous therapies under certain circumstances. We're also looking at legislation in Texas and Arizona and Utah. There are many states that have passed laws or are considering passing laws that will allow regenerative options, to help get these costs down and improve care. Again, Hemostemix, 20 years of clinical science and development. We're going to now talk about our phase 1 and 2 trial data. We will talk more about our GMP manufacturing partners that is required per the Florida SB1768. And then what does commercial expansion look like? What does that even mean? Commercial expansion in our context of being not FDA approved without reimbursement really means that a patient will have to pay out of pocket for these therapies. And so that's very challenging for anyone to generate out-of-pocket costs. In our case, as we've talked about on this call and many others, coming around $42,000 out of pocket, which helps cover the manufacturing, the culturing of the cells, the education, and the training of the physicians' costs. We've also talked about how the commercial use of ACP-01 is heavily aligned with our clinical study protocol. They are published. We then train on those protocols so the doctors are operating exactly closely to the clinical trial protocols, the data collection to gather the real world evidence so that can be used and given back to our partners at FDA so they could see that evidence for themselves. And of course, all the collection of any safety or adverse events. And we'll talk a little bit about that. But the insight here is that blood-derived angiogenic precursors specifically programmed for neovascularization, is a clinically viable area of discovery. And let's talk a little bit about how the mechanism of action works very quickly. So it's a powerful paracrine angiogenesis effects through the autologous stem cells that are cultured, in our GMP facility. Number one, through growth factor secretion, CD34 plus cells secrete VEGF, angiogenin, and CXCL8. There's tissue homing. So the ACP cells home into the site of need via CXCR4 and CXCL12 axis. There's further cell recruitment where ACPs will recruit peripheral CD34 plus cells and the in-key cells that helps to reduce inflammation and pain. And then there's a peak effect. So in our studies, if you go back and look at it in aggregate, there is a peak effect through the first 3 to 6 months. And so there's more work to be done on understanding, how many injections are required over what period of time. And we're going to show you now some of the data that we've seen based on one injection of ACP-01, or I should say one treatment, and what is that peak time, and then what is the durability of that? When we're mimicking body's natural repair process with no foreign material. These are the phase 1 and phase 2s. These are safety studies in humans, 298 patients. There was one death in one of the studies through one of the heart patients who had a silent myocardial infarction, who unfortunately led to this individual's death as it related to, as mentioned, a silent heart attack that was not picked up through the screening process. And that was on the cardiology side. On the CLTI side, our 3 studies, Zabo, Henderson, and Multiranga, an open label phase 1 of 20 patients, phase 2 of 47 patients, and then this 2009 Multiranga study was 6 patients in an open label randomized study. All 3 were for no option CLTI. And now let's share some of this phase 2 data with you from the Henderson reexamination study published February of 2024. Study design of 67 no option CLTI patients, 46 treated on ACP-01, 21 placebo. When we look at the ulcer healing results, these groups had ulcers. There was a subgroup, N of 21, with a mean ulcer size of 1.46 centimeters squared that was reduced to 0.48 millimeters squared at 3 months, p-value 0.01. So this is an average size of a small strawberry, an ulcer about this size, being healed almost to the size of a grain of sand. So this was key healing efficacy data, based on this N of 21 sample, which provides some of the efficacy data, per that study. So please go read that study. I hope you'll understand it, digest it. We can talk further about that efficacy data. And also you'll see a very favorable safety profile because these are angiogenic cells that are autologous from a patient's own blood, a very favorable safety profile that we'll talk about shortly. And we talk about that on every single call. I want to understand the safety data. The 1-year outcomes, amputation rate of 4.8% versus 25% in the control group. mortality rate of 4.8% versus 12.5% in the control group. The 25% is very much aligned with typical Medicare data. And so the treated group, again, 4.8% amputation versus really the average of 25%. The long-term follow-up of up to 4.5 years, there was 83% complete healing, no pain, and no major amputations. And in terms of safety, there was 0 treatment-related complications that were recorded in the study. There is a best practice on considering readministration to further optimize results. That'll be a topic for future studies that are in our pipeline. This is our paper presented to the Society of Vascular Surgery in 2023. This was an early read that is very essential and important for vascular surgeons, that talks about the method of administration. And you'll see here the 30 injections of 1 cc of stem cell, in the calf muscle and on the foot here, that led to these 2 patient case studies that do reflect changes in healing in the wound size. I'll just read this to you. There were 12 patients at 2 treatment centers with CLI with no interventional options were enrolled, 10 male, 2 females, mean age 76 years. Prior to treatment with ACP-01 or placebo, 3 patients had ischemic rest pain, 8 patients had ulceration, and 1 patient had gangrene. Post-treatment, 1 patient with unremitting rest pain and toe gangrene required a below-the-knee amputation, and 1 patient with gangrene of the 1st to 3rd toes required a 4-foot amputation. The healing of ulcers and resolution of ischemic rest pain occurred in the other 10. So 83% had healing of ulcers and resolution of ischemic rest pain. There were no clinically significant safety issues. Outcomes have been maintained for up to 4.5 years, 3.5 years for 2 patients, 3 years for 1, and 1 patient did die after ulcer healing secondary to congestive heart failure at 6 months. The conclusion of this poster: preliminary results are promising with an acceptable safety profile and no ACP-related adverse events. Early data indicate that many ischemic wounds can improve or even heal completely with diligent wound care, close follow-up, and appropriate support. Further investigation and prospective study is critical to better delineate accurate prognostication, to identify new treatment modalities, and provide improved care to patients with ischemic wounds who have exhausted other revascularization options. We've talked about how ACP-01 works, the CD34 plus enriched cells homing to ischemic tissue, the recruitment of peripheral cells, and the NK anti-inflammatory cells achieving a peak effect. So now let's talk about the administration and physician onboarding, and this is going to provide some very important details that I think are essential to understand how to think about the context for ACP-01, how it can be administered safely, and then really what happens in the day-to-day clinical practice. So we're going to talk about how would a physician, probably a vascular surgeon, treat their first patient. It's someone that a vascular surgeon would have identified as not an option for other revascularization procedures. We're going to talk about how do you screen and identify for those patients, how to gather informed consent, how the blood draw works, the peripheral blood collection. That's where 250 cc's of a patient's peripheral blood is drawn. It is then sent to the GMP facility for cell reculturing, where the cells are manufactured and produced safely, go through quality control. They go back to you plus 7 days, and then there's a day 0 injection protocol and a 12-month structured follow-up process that we're now going to go through. This is really the overview of the clinical care workflow. We've covered this in the past, but generally, a patient is referred to you, or it is from your existing patient population. Hemostemix will work with you to help establish the qualification. What are the right diagnostics? The patient will go through a physician review. Either a Hemostemix physician will help qualify, review the diagnostics, determine the eligibility for Vasel ACP-01 therapy, working with you as a clinician. help you understand the treatment and follow-ups, payment and scheduling, and then all patient notification, and informed consent, payment options, financing options, travel coordination, all the things that are needed to help a patient get to and from the clinic safely, all under best practice care. Florida's compliant patient consent protocol is very strong. It's important. It ensures that a patient understands that these are not FDA-approved options. They understand in our case, we want them to understand the phase 1 and phase 2 data for why angiogenic cells are a potential consideration for no option therapy under compassionate use. How to go through medical consultation, how to talk about this with your primary care physician, how to have discussions with your vascular surgeon, and to set realistic expectations that there are no outcome guarantees. And so the clinician will have this conversation with their patient, and they together will decide if it is an appropriate therapy for consideration. The inclusion and exclusion criteria is very important. I'll start with the exclusion criteria. So some patients should not be considered for ACP01. And this is actually a short list. We have a more robust administration guide for our physicians, but any active infections, wet gangrene, or large ulcers that are very severe, greater than 10 centimeters squared, the patient should be automatically disqualified. If the patient is at risk of an amputation within 4 weeks, or has risk of life expectancy less than 6 months, or recent MI or stroke, that patient just simply should not be considered for ACP01. For inclusion criteria for task 2 CLTI diagnosis, if there are no option for revascularization, and they're on the optimal medical therapy standard of care with statins, antiplatelet medications, and pharmaceutical care, that would make for a good candidate. There are other inclusion options which we will all review together in the administration guide if and when we have that conversation. If a physician has a patient that they would like to consider for ACP01, that is essential. So the screening and the blood draw. So days, -30 to day -7, there's a screening period, gathering a full history of the patient, understanding their pain documentation, ulcer photos, vascular quality of life, standard of care lab data, through a visit where they will have a peripheral blood draw, shipping same day to Cytoimmune, which is our GMP facility. Actually, this is based in the United States and Puerto Rico, coming back 7 days later with a pre-scheduled meeting for re-injection. And then for the injection day, the intramuscular injection protocol, confirming the patient's fitness, the injection protocol of 31 cc injections into the calf muscle and into the top of the foot using a 23 gauge needle at 1.5 centimeters depth to distribute the ACP cells evenly across the muscle for administration into the limb. It's essentially up to 200 million cultured cells in 30 ml in 6 syringes, right? So the physician gets a kit with 6 syringes, 30 milliliters with up to 200 million cells. Patient comfort is important. Analgesia is important at the physician discretion for the injection. And then post-injection monitoring up to 2 hours post-injection, using a grid pattern for even distribution. And of course, documenting anything, if there's any spills or any major adjustments to the administration of care. There is immediate safety follow-up, 48 to 72 hours, looking at vitals, ECG, leg exam, and blood cultures, releasing the patient when they're stable, and then, of course, reporting any adverse events. Typically, any AEs are around injection site soreness, or any injection site reactions being the most common side effects. Long-term follow-up are structured up to 12 months, again, looking at pain scores, analgesia use, ulcer size, ankle toe pressure, Rutherford classifications, quality of life, and chemistry labs, blood labs. We will continue to talk about safety of the ACPs themselves, the administration guidelines, team coordination, and guideline compliance. Real-world data collection is a big part of our therapy protocol. As mentioned, our phase 2 clinical protocol is how we will match any commercial use, for example, in the state of Florida or in other countries around the world. And that real-world data collection is a big part of what we would like to send back to FDA so they could see every bit of data that we have. I'll just list my name here, Kroom Lawrence, Chief Commercial Officer, Lawrence at Hemostemix.com, to help with any physician account onboarding, to make sure that training and education, logistics coordination, and access to our medical affairs is available. So I'll just say a couple more words and we'll wrap it up. I know we're now on to, I guess we're a little bit, or I guess we're on 36 minutes, not too bad. For a physician account onboarding in the state of Florida, there will be a services agreement that we will sign together that really matches the protocols per SB1768. We want everyone to understand that everything that is required in that law, we will then move into training, setup, education on stem cell administration and follow-up care, all related to finding a patient that meets the inclusion and exclusion criteria for safe and effective administration of ACP-01. I think we can skip through that. We've talked about our manufacturing and compliance details with cytoimmune therapeutics here in the United States that will reculture the cells. We offer live training sessions. We have webinars such as these, ongoing support. Please reach out anytime. We'll have numerous research opportunities that we'll also be bringing forward, focused on our physician responsibilities, Hemostemix responsibilities, required disclosures, compliant templates to help you deliver care, and patients that come in through our company looking for clinical studies, or patients that you might find in your local neighborhood in Florida or around the world. So we, just by way of a summary, the things that stick out for me is that we do have the potential to save more limbs today. There are too many patients that are slipping through the cracks, especially minorities, that don't even have access to the revascularization procedures or to angiography that would help even provide insights into what's happening below the surface of the leg. We've talked about potential cost savings to the system. If there's a 5x or even a 10x cost savings as a result of delivering a standard of care more evenly, we certainly are focused on cost savings to the system. But importantly, if you're looking at a 50 to 70% mortality rate in year 5 by not receiving best-in-class care, it really becomes a family issue. And so, we're keenly aware of the out-of-pocket costs, cost to the system. What does it mean to have a loved one who is not living in pain, who does not have open wounds, who's able to save a limb, and frankly, save their life? And that is the promise of the stem cell revolution, in a nutshell. It's very, in our view, very clear. The evidence continues to be built, and we just look forward to taking all of your questions. Please reach out to me directly on X, on LinkedIn. You have my contact information. We would like to hear from you, whether you're a physician, whether you're a patient, whether you're a regulator, whether you are a part of our Friends and the Patient foundations. We're going to be attending a couple events in December. One is in San Diego this weekend, Diabetic Foot Update at the University of Texas in San Antonio through the Limb Preservation Foundation. And then we'll also look forward to seeing you in Key West, Florida in 2 weeks at the Innovations in Wound Care Conference. Anyway, thank you so much. We welcome all of your feedback and questions. We welcome you to the Hemostemix community, and we appreciate everyone's efforts to bring what we think is transformative medicine to market. So have a great day. Thanks everybody for tuning in on this Thursday. And please come back each week as we go through our Vessel Health Talks. This was number 17, and we will continue to keep these conversations going until we can really bring this transformative care to market. Have a great day, everybody. Thanks for tuning in. We will see you soon. Thank you.